All right, Dr. Schroeder, we are live. I'm just going to get started really quick. So welcome everyone. Today is our live Q&A with Dr. Schroeder. Dr. Schroeder is a highly sought after expert pulmonologist here in the Beverly Hills area, and he's also an esteemed member of the Lupus LA Medical Advisory Board. And he's joining our community here today to share his expertise around lupus in the lungs with us. We've already been getting questions submitted from all of you, and we have some new questions rolling in right now. So if you'd like to share a question for Dr. Schroeder, please drop it in the comments below or send us a DM if you'd like to ask your question anonymously. And with that, I'll turn it to you, Dr. Schroeder. Would you mind telling us a little bit about yourself and your practice before we dive in?
Yeah, I'm happy to, and thank you, and thanks for having me today.
Of course.
I'm a pulmonologist, so I'm trained in pulmonology. A little background on myself. I did my training at Cedars-Sinai. I was also an intern and a resident there. During my time in the ICU as a resident, I had a woman who had lupus who let a cold go too long, like 3 days too long. And she was a mom and she owned a restaurant, and she got really sick, and she ended up with me taking care of her in the ICU. And I intubated her. I had to put the tube down her throat. And the last thing she said to me was, "Am I going to be okay?" I said, "Yeah, you're going to be okay." And I intubated her. And that's when I started to get an interest in lupus. So, what is this disease that, this poor lady who seems healthy let something go for too long, and now I'm taking care of her in an ICU. So that kind of started that journey. That was over 20 years ago. And to make extra money when you're a fellow, you have to cover other doctors' practices. I started covering rheumatology practices. So I had more contact with all types of autoimmune disease, but predominantly lupus. So, my interest in autoimmune disease in the lung goes way, way back. And I've enjoyed years and years of really taking care of a lot of autoimmune patients in our catchment here in Los Angeles, Beverly Hills, and even international patients. So I really take pride in kind of having that part of my practice and having that part of my brain dedicated to autoimmune disease and lungs. So really the first question that came up, or that has been sent in, has to do with COVID. So there's a couple of questions regarding COVID. I think the first would be, how do I approach a patient with autoimmune disease who has had COVID and is now having prolonged lung symptoms or pulmonary symptoms? My approach is this. One, we need to figure out first if you're in a lupus flare as a result of having COVID. So at that point, I would, point you back to the rheumatologist and say, why don't you go get some blood? Let's see what the numbers are. Obviously, I can listen to patients. I can measure airflows. We can do CAT scans, but it may be as simple as treating the underlying cause. Secondly, I always look for secondary infections. COVID really doesn't travel with other infections the way some viruses do, but it never hurts to look for an undiagnosed pneumonia that kind of you lived through and it's still there. I can still see it on the x-ray. Then we would treat you differently. And then lastly, and this goes for kind of everyone in the COVID spectrum, having symptoms that are going out further than 3 weeks, let's say, and it depends on who you read or who you ask, when does long COVID start? I've heard a million different dates, but let's just say 3 weeks. Those people I treat like they have asthma. So I basically explain, listen, you've had an inflammatory issue in your lungs as a result of a virus. It loves your lungs. It loves getting in the linings. We need to treat you like you have asthma. Give me 2 weeks and then let's reassess. So, I don't think the textbooks have been written yet on how to approach this, but, as a single clinician out in the community, I've had a lot of success starting someone on typical, medium to high dose asthma medicines to get the lungs open again and decrease the inflammation.
Wow.
So
Wealth of knowledge here.
That's COVID in the nutshell. And then why don't we make our way through the questions that were submitted previously?
Yeah, definitely. just to get us started, somebody asked, how do you know if you have pleurisy? Can you talk a little bit about what that
Yeah.
process is and how someone might know or experience symptoms of it?
Yeah, the nickname of pleurisy is the devil's grip. Okay, that's what they used to
Ugh.
call it. If you feel like a large demon has its claws dug into your chest every time you take a breath in, that's pleurisy. Okay, so it's called the devil's grip. Um, the etiology of pleurisy is inflammation on the inside of your chest wall. There are tons of nerves on the inside of the chest wall. Your lungs themselves don't have a lot of sensory nerves, especially that far out where it's touching the inside of the chest. But you better believe there's a ton of nerves just on the inside of the ribs. The issue with pleurisy is if there's some inflammation that's weeping out of your lung, and as it slides on the inside of the chest wall, that inflammation stimulates those nerves. It's one of the worst pains someone could ever have. And you have it because if you don't breathe, you don't have the pain. The minute you move your lung or the minute you change positions and that lung slides on the inside of your chest wall, that's when it sets it off. And it really is called the devil's grip for the right reason.
Oh man. Thank you for that description.
Yeah.
Um, our next question is, are there specific signs and symptoms of lung issues versus cardiovascular issues? How can you tell the difference when you're having a problem?
You know what? It's very hard. So cardiac and pulmonary symptoms are very closely intertwined. That's something that I have to figure out. That's why people come to my office, because even heart issues can present as shortness of breath. So unless it's obvious, like an infection and you're coughing stuff up out of your lung and you have a fever, etc., you can figure it out that way. But really, I wish it was easier. You need a specialist or like a sharp general medicine doctor to help sort it out. So it's not easy.
Okay. Our next question is, does pleural effusion always show up on an X-ray, or what kind of test can show this?
So that's a great question. And they don't always, because x-rays are hard to read, and if it's a very small amount of fluid or they don't do a side view, you can miss it. So that's why I always do a side view in my office. The other interesting thing is if you have a pleural effusion, you're not going to get pleurisy, at least where the pleural effusion is away from separating the lung away from the wall. So to backtrack, basically a pleural effusion is fluid that's between your lung and the chest wall. It's in this potential space that that fluid needs a place to go. There's various reasons you get pleural effusions, but it's fluid where it shouldn't be. So it separates the lung from the chest wall. So that will miraculously make the pleurisy or pain go away. So that's something I would pay attention to when I'm doing a history on a patient. Oh, you had pleurisy and now it's gone. Interesting. And now you're short of breath and you can't take a full breath. Oh, interesting. Well, that means maybe that inflammation caused so much weeping out of the lung that you have a collection of fluid now. So, we actually see pleural effusions all the time. We see pericardial effusions a lot. Okay. So that's when it gets between the heart and the sac around the heart. Those are often incidental findings. And most of the time we watch them and we don't get crazy with the needle because, God forbid, we're trying to remove a teeny weeny little pleural effusion or pericardial effusion and we pop your lung by accident. So a lot of times the risk of a procedure is much higher than any benefit we could expect. And your body wants to get rid of that fluid anyway. So reasons to check it, reasons to use a needle under ultrasound guidance would be, why is this pleural effusion there? It doesn't make sense. Maybe there's an infection. We need to make a better diagnosis because everything's not adding up into a classic picture, or you're becoming short of breath. The pleural effusion that makes someone short of breath is like a liter of fluid or more, maybe half a liter if you're a small person, but like we're talking about very significant amounts of fluid that anyone can see on an X-ray.
Interesting. Thank you so much for the thorough answer on that. Our next question is, what happens when lupus attacks the lungs? Like, what's going on when there's lupus activity affecting the lungs?
Yeah, so there are phases. The first phase would be inflammation. That bogs down the transfer of oxygen, that thickens everything up in there. The membranes get thicker. There's inflammatory cells down deep in the airways that shouldn't be there. So it just gums up the works. It makes it hard for oxygen to get through out of the air into the blood, have an exchange. So that would be acute inflammation. That's what we hope to prevent. If we find it, we get aggressive and we try to decrease it. The end game of inflammation in the lungs is that it causes scar tissue. So that's what we don't want. Once we get there, it's like the horse has already left the barn. There's not a lot we can do. So we need to stay ahead of it. So, how do I figure that out? We do the most sensitive test is actually the breathing test called the pulmonary function test, where you estimate the diffusing capacity. So like I was saying, the works way down in the lungs get gummed up, not a lot of exchange of gas. So you can pick that up with a breathing test with a pulmonary function machine. That's the early warning system. And that's when, I call up my friendly rheumatologist and say, hey, let's go after the underlying problem once again. The other thing that a lot of doctors kind of miss is it's not the lungs. Much of the time when I see an autoimmune patient, a lupus patient, I say, your lungs look good. It's the chest wall. Okay. So it's the ribs aren't moving because they have back issues and the ribs aren't swinging. The connective tissue in the chest is inflamed. So you don't want to take a deep breath because it hurts, or you just literally lack flexibility in your chest wall. And that's a typical thing that a doctor who's not tuned in can easily miss. And that's that horrible thing that happens to any autoimmune patient where you go to the doctor, you're sick, you don't feel good, and they say, this test looks great, get out of here, right? So look, I think most lupus patients have been in that situation. What that doctor is forgetting is it's the chest wall. The chest wall's not working, right? And that's what moves your lungs.
So interesting. And you're right. That is something that lupus patients face as a challenge so much,
Yeah.
With practitioners from time to time. It's just it can be so confusing also to communicate about symptoms and what you're experiencing.
And it's demoralizing.
Certainly. Another question that we received is, what are the limits of X-ray with looking at the lungs? Do you always have to have a CT with contrast to see what's going on if you have damage?
Yeah, I mean, X-rays aren't great. X-rays are really hard to read. They miss a lot. They're really, in my opinion, a screening tool. X-rays are great for bones, but it would have to be even an obvious rib fracture. My experience with patients with lupus is you end up on and off steroids enough to have bone issues, and then you break ribs because you're coughing. A lot of times you might not even see a cracked rib on an X-ray. So X-rays are not wonderful. CAT scans are amazing, except for they have radiation. I do not get contrast on CAT scans because you just don't need it anymore. The only reason, the example or the exception would be if we're looking for blood clots, which obviously can happen in autoimmune disease and can become a very real issue, especially people with a positive lupus anticoagulant, et cetera. So use the contrast dye. That's happening in the emergency room, right? That's when they're really looking for the blood clot. But to see lung damage, the CAT scan is necessary. The government sets the limit for how much radiation they think is safe. I think with the normal amount of radiation from a normal CAT scan, not high resolution, you can get 5 CAT scans in a year. Not what I'm telling people to do, but that just gives you an idea, or gives you some perspective as to how much radiation you're getting. There are some instances where you do need a high res. Let the pulmonologist figure that one out. That's looking for specific types of kind of fibrosis, and the machines are so good these days. Like most of the time I don't need it. I can see the fibrous tissue without a high res. So, rule of thumb, if you're getting checked out, if there's any issue, don't be afraid to get a CT scan. Know that unless they're looking for blood clots, you're not going to get contrast dye. And they really, someone needs to explain why they're getting a high resolution, meaning more radiation CT scan. There was one other thought I was thinking, I can't remember. Oh yeah, a lot of times insurance companies will say you needed to get an x-ray first as like a hoop to jump through to try to slow down your care. If that's the case, you can get 200 chest x-rays in a year and still stay under the limit. So not a ton of radiation on a chest x-ray.
Thank you so much for explaining all of that. It's a great frame of reference. Is difficulty breathing a symptom of lupus in the lungs?
It depends. So, that's the most that was the question. That's the question you ask a med student and they freak out because there's too many reasons to be short of breath. So lupus is on the list. Look, if you're diagnosed with lupus and you're telling someone you're short of breath, that the approach needs to be, we can't forget that you have lupus, but we have to do the fundamentals anyway. So, don't get caught in the everything's lupus scenario, with lazy thinking on the part of who's taking care of you. So no, not everything is lupus, but lupus issues can definitely cause shortness of breath, but there needs to be like a very wide net cast, because you don't want to miss obvious stuff.
Sure.
And that's the danger. Like, that's the danger that a lupus patient is in when they're in with the doctor, that they're just going to not do the basics and blame lupus all the time.
Sure. Our next question is shifting a little bit to the diaphragm. The question is it possible to have endometriosis on your diaphragm? I have trouble taking a full deep breath around hormone changes. It feels like my breath gets stuck under the bottom of my rib cage where my diaphragm is.
Yeah, I've seen it. It's called catamenial hemoptysis when it even gets in the lungs. So you can actually get it's uterine tissue that gets in the lungs, or it can get in the chest wall, between your lung and your chest wall, in that space where the pleural fluid might collect. So that's a real thing. It happens because the fallopian tubes are actually open-ended and they're just waiting for the eggs to drop out of the ovaries. But the tissue that comes out when you're having your period is lining of the uterus, right? So the lining usually goes south. If it goes north, it can come out of the fallopian tube, hang around in the abdomen, right? So then, that'll cause its own issues. But there are pores in the diaphragms, believe it or not. I think they're called the pores of Kohn, if my memory serves me correctly. And endometrial tissue sneaks out, and it sneaks up into the chest.
Wow.
And you don't want to be exciting to doctors, but doctors get excited when they find that. The way that every single patient I've seen, I've probably seen half a dozen people, maybe more, with that, go on birth control pills to kind of suppress the hormone fluctuations so that tissue doesn't get big every month. So that settles it down. So there's no term for the chest, but you've probably all heard of endometriosis. That's the mechanism in the gut or around the guts of tissue that snuck out of the fallopian tubes, and now it's like little pockets everywhere that inflame or get big, with the monthly cycle. So definitely yes, everyone, you have to make the diagnosis, unfortunately, by getting either fluid out of that space, or sometimes we stick a little scope in there and we look around and take a little pinch, and it's easily identified in the pathology lab. And then the treatment would be hormones if you can take hormones.
Wow. Okay. The next question is pneumonitis the same as when you catch pneumonia?
No. So this is just really a language issue. Itis just means inflammation. So pneumo, lung, itis, inflamed. Diverticulitis, diverticula coming off your intestines, itis, inflamed. So that's like speaking medical language. So basically, pneumonitis is inflamed lung from anything. You could inhale smoke. You could choke on something and spray your lung with stomach acid. So pneumonitis, unless it's a chronic inflammation, is always a happy thing. It may look the same on an x-ray as pneumonia. Pneumonitis gets better in 3 days, right? You don't need antibiotics. Pneumonia means there's infection. So the three ways to get a pneumonia or the three ways to get an infection are bacteria, viral, or fungal. You can't forget about fungus, especially on people with immunosuppression, right? So once again, if I see a chest x-ray and I see some haziness and the person hasn't thrown up or had some aspiration or some insult, like they were in a car accident and the airbag went off or something and they inhaled stuff, then I'm thinking infection, but then you need a wider net. And then you need to say bacteria, viral, fungal, do the workup.
Wow. Can I just ask a sub question off of that?
Sure.
Is it difficult to determine whether it's fungal or viral? Is it straightforward, or is that kind of hard to determine?
You have the pressure that the doctor is under when they're dealing with pneumonia is that we know that the faster we treat it, the better people do. So the clock is really ticking. So we never get the luxury of doing a culture or doing some investigation and waiting 72 hours for something to come back. So you're making your most educated guess. So really the approach, especially in someone with an immune system that's overactive, right? That's lupus. And then you're giving them immunosuppressives. So like now you don't even know what the immune system's doing or whether it's working for you or against you, is shoot first and ask questions later. So if I think there's fungus, I treat for fungus and bacteria. You're going to treat for bacteria, but you got to treat for fungus up front, and then you wait for stuff to come back, and then you can pull back. Then you can narrow your treatment. The other thing is on a CAT scan, you can look at it and say, this looks fungal. It has a different appearance. This is how fungus looks in the airways. This is the fuzzy little fungus balls that I can see, in the lung parenchyma or the tissue of the lung. So you're under pressure to do the right thing up front, but it's okay to, in other people's opinion, over-treat up front, but then you got to pull back fast.
Okay. Another question that we received is it possible for diaphragm function to change if the nerves that control it are inflamed?
Yeah, for sure. I've seen it. So the phrenic nerve comes out of your brain, goes down the middle of your chest and innervates or serves both diaphragms. And it's like, I don't know, it's kind of a thick nerve, as nerves go, it's kind of medium size. It's not thick like the vagus nerve. It's not like a huge, trunk. So it is at risk for running through areas in your body where there could be extra inflammation, and it'll slow down the function of that nerve. So I've seen that. And then basically the diaphragms that are going like this all the time, like pistons, you inhale, like you're like a human syringe and you suck the air in and then it relaxes. And then you suck air in and it relaxes. One of them won't work. So you're just kind of going like this, right? So when you do an x-ray, so that's like a good x-ray thing, because on an x-ray, their diaphragms look like this. That's pretty easy to pick out.
Interesting. Okay. Our next question is, how is pulmonary hypertension treated?
Pulmonary hypertension needs to be treated by a team. Okay. So you're not doing yourself a favor by letting a community doctor, even like me, okay, I'm connected to a huge medical center, but at the end of the day, I'm a community doctor. I'm not a team who can handle pulmonary hypertension. Since I graduated over the last 20 years, there have been major improvements. There are a million ways of kind of like slicing it thinner and thinner and thinner as to why it's happening. There's better drugs. Bottom line is you need to go to a med center and you need the team taking care of you, and they need to do a ton of tests on you and pick the right medicine. Okay. And there's great medicines for it. So do yourself a favor. And even if you have to get in your car and drive, head for Cedars, head for UCLA, head for SC, Loma Linda. We got a lot of places in Southern California.
For sure. The next question is shrinking lung real? If yes, how is it diagnosed?
It's real. I've seen it. It's rare. You diagnose it with a breathing test and with a CAT scan. So, the breathing test will show these shrinking lung volumes. That's part of the pulmonary function test. Has three parts. One is how fast you can move air. The The other is what are your volumes at different times of your breathing cycle? And lastly is how well does gas get through the membrane? So yeah, breathing test, CAT scan, easy diagnosis. You end up going back to treat the underlying issue. There's no way to stretch the lungs open. From my point of view, not being a rheumatologist, the only other angle with that is to strengthen what's around your lungs. Work on chest wall strength, chest wall flexibility. There's a million ways to do it, which leads to kind of the next question. And people ask me this all the time: what exercise should I do to improve my lungs? And when I first started out, I didn't understand that question because I thought, well, there's no muscles like that move the lungs. How do you strengthen a lung? It doesn't work. I think what the patient's asking is, how do I get my lungs to move better? And any cardio, okay, anything that will increase your heart rate and increase your respiratory rate and have you do volume work, okay, moving volumes with your lungs. People who are on supervised programs always fill out the questionnaire at the end saying they feel better, okay? You don't need to medicalize it. You just need to get out and do it. And, you know, I have a patient who lives near the Rose Bowl, and I said, you need to get out there and walk around the Rose Bowl. It's flat, it's nice. And he's like, well, I can't do that. It's 3 miles. Well, yeah, you can't do it today, but like, I want you out there, and when you need to turn around, and, you know, give the guy 6 weeks, he's going to make it around the Rose Bowl. So
Yeah.
you don't need to have a pulse ox on and leads on you to move your chest wall.
Going back really quickly to the comment that you were making about the differentiation with chest wall issues versus lung issues, and how sometimes that can be overlooked if the physician isn't really aware that there can be issues with like the chest wall. Is that something that is evident on imaging, or is that something you just know from your clinical experience?
You need to be good at reading the breathing tests.
Okay.
And, you know, for example, we measure blood pressure. That's 2 numbers. But if we get into the heart and we start measuring a million things on their heart, we come up with like 100 numbers. Like if you look at an echocardiogram report, pulmonary function is the same way. So we can check a pulse oximetry and we get 1 number. By the time you're done doing pulmonary function testing, you've got, you know, hundreds of numbers to look at. So it comes down to detecting patterns and being really kind of acutely aware of the fact that there could be increased kind of chest wall resistance. And that's not an easy answer. And that's literally, you don't even learn that when you're in your pulmonary training and you're learning how to read these pulmonary function tests. That just comes with time.
Wow.
Well, and looking at the patient and holding their chest when they breathe and seeing how far, you know, you hold their back and you put your thumbs together. I've had patients where they breathe and my thumbs don't move because they're not expanding. They should be moving, right?
Wow.
They take a breath. That means all they're doing is their diaphragms are going up and down. They can't recruit their chest wall to open up and increase their capacity. And you need to do that when you're in a time of increased demand, which could be as simple as going upstairs.
Interesting. Okay. Our next question kind of dives into some of the co-conditions that a lot of lupus patients face, one of which is Sjogren's. And someone asked, if you also have Sjogren's in addition to lupus, can the dryness affect lung mucus and breathing?
Yeah, for sure. And, you know, I take care of autoimmune patients where they just make the thickest mucus ever. And no one can, we don't even have the right test to figure out why, right? And they're not per se lupus. They may end up with a diagnosis like mixed connective tissue disease, or, you know, other kind of even sub-diagnoses, and they make thick mucus, which can really work against you, because I don't want that person taking antihistamines and making it thicker and making glue.
Sure.
And we have this kind of, well, I'm stuffed up here. Why don't I take Sudafed? Why don't I take Benadryl? That creates cement in their lungs. So it becomes this real balance. Sjogren's, obviously, dryness is a big deal. Eyes, mouth, that extends down into their airways. So a couple of tips on how do you keep the mucus loose. 1, you stay hydrated. Okay, so fluids. Don't overdo it. You know, 2 liters a day of your favorite fluid that's not alcoholic or not highly caffeinated will stay in you. Okay, so don't go over 2 liters a day, and then listen to your doctor if you have other fluid issues. Something called N-acetylcysteine or NAC. That's something I ask all the people who I smoke to take. That cuts up mucus, makes it easier. And then, everyone knows what Mucinex is. Guaifenesin that's the base ingredient. That's a super old medicine, and it used to be known as an expectorant, right? So that just loosens mucus. So you don't have to get the Mucinex with all the letters after it, DX, DM, and all that stuff. If you just get regular Mucinex, it will loosen mucus.
Wow, it's interesting that you mentioned NAC. We had a rheumatologist recently talking about the benefit in lupus for antioxidant properties a few weeks ago.
Yeah.
It's interesting.
No, 600 milligrams a day. It's sold at health food stores.
Nice. And we're almost wrapped up. Do we have time for just a few more questions, Dr. Schroeder?
Sure.
So what is the best way to protect your lungs from lupus flares and damage?
Treat the underlying disease. And it's the unglamorous, not very satisfying advice that we give people, which is get sleep, get exercise, not too much, not too little, have good nutrition, be in good relationships with people, get toxicity out of your life. So toxicity can be in the form of relationships. Not that I'm a psychologist, but it's pretty easy to see sometimes. Nicotine, too much alcohol, lack of sleep, working too hard, all that kind of stuff. I don't need to tell lupus patients that, because unlike most people, when you have lupus and you overdo something, you get immediate feedback, because then you're just miserable, right?
Mm-hmm.
People without lupus go way too long doing all those toxic things. So not the glamorous answer, that's the hard answer, but it's the right answer.
Yeah. We had somebody ask about upper respiratory tract infections. Jessica says, if it seems whenever I get a URI, I get pleuritis. I also have prolonged respiratory symptoms, like 3 weeks of like mucus and congestion, and sometimes I get pericarditis. What can people with lupus do to prevent, manage, and best treat symptoms like these?
Yeah, so that's a nightmare. And that's the kind of thing that makes people very worried about getting any infection, and I can't blame you. The pleuritis is made worse when your airways get tight. Okay, so if we pull the air in with the diaphragms, our lungs get pulled by our chest wall. That's that chest wall with all the nerve endings. So if your airways are a little tighter than usual and it's harder to suck air through them, there's more pull, and you pull on your lung more. Okay. So what does that mean? It means the area that is angry already and wants to be pleuritic and have pleuritic chest pain has another reason, because there's more pull on it. So keeping the airways open and treating yourself even temporarily with bronchodilators can unload that chest wall tension. Okay. So that's a huge tip. The other is mucolytics, like that NAC. Things that make your mucus more slippery, like the Mucinex or Guaifenesin. And then the pericarditis, that's a tough one. There's no kind of active plan, when that happens, but it comes down to limiting the amount of inflammation that your body creates, which is the problem with lupus. And I know we can't control it, but we can be in a position to not make it worse. Okay. Which is the resting part. Okay.
Okay.
So I wouldn't run to the rheumatologist every time and get my labs checked and see what the numbers are, because you kind of already know what's going on.
Understood.
Right?
Yeah. And then we have another community member asking, is it best to use Wixela and albuterol at the beginning of a URI with persistent mucus, even without wheezing or shortness of breath?
For some people, yes. Okay, but you need a track record. So the previous question, every time I get sick, I go down the tubes. If it's that person, yes, get it done, get it on early. Have a pack in a safe place at home, ready to rock and roll on Friday night when you start to get sick and no one's answering the phone at the doctor's office. Okay, so that's kind of a play from the asthma textbook, which is, how do I know I'm having an asthma attack? there's different criteria, but my asthma patients have a Medrol pack, a higher dose inhaler, and antibiotics at home for Friday night when they get sick, because no one gets sick at a convenient time.
Of course.
Yeah.
Okay. And then those are our live questions that we just wrapped up. But I wanted to just quickly, before we let you go, Dr. Schroeder, ask, in our previous live that we did with you, you spoke about walking and kind of expanding your lung capacity to the ability that you can. Do you have any notes that you would give to lupus patients about like breathing exercises, or any programs that you recommend other than just walking, or do you typically just recommend exercise?
I mean, okay, so I do. I don't know if they're appropriate. Um, so it just depends on what you can do. So if you're limited physically, I want you to do whatever you can do. Okay. And you can be that guy at the Rose Bowl who's not going to make it around the Rose Bowl, but you get out there every day and one day you're going to make it around the Rose Bowl, right? That's someone walking on flat at sea level.
Mm-hmm.
Okay, so that's a minimum. The maximum, okay, and this is real, would be to really improve your compliance of your chest, because you're really trying to increase chest flexibility, your ability to take in a bigger breath, right? How compliant are your diaphragms? How strong are your diaphragms? The craziest one I've heard of, and I've done this myself, and it's not fun. But if you swim, so there's a drill in swimming where they do this, on swim team to try to increase capacity. And you basically, let's say it's a 25-meter pool. You say you're going to do 5 laps down and back, 50, right? So the first time you do the lap, you get 5 breaths. Then you get 4 breaths. Then you get 3 breaths. Then 2, 1, and then you can even do a 0 breath. And this is doing freestyle. So that is a huge demand on your capacity. And I'm not saying that anyone can expect themselves to get into a pool and do that, but the whole idea of not breathing while swimming, that's a major kind of compliance builder, muscle builder exercise. I'm answering the question because you asked it.
Yeah.
I'm not, I don't tell my typical patients to do that unless they're a swimmer. But that's kind of the coolest one I've ever heard of. I think there are things on the market that are like breathing exercisers, et cetera. I've never had any luck with them. They're kind of like, they create resistance, and maybe these elite training programs, they'll show people running on treadmills hooked up with stuff and they have something in their mouth. That's kind of a little silly. So once again, I'm just getting back to do your cardio at a higher level for a little longer. That's how you do the training. And look, pulmonary rehab is just being on a treadmill. That's it. And you're being monitored. Okay. That's it. And you've got a tech there. That's pulmonary rehab. People always get better.
Wow. Okay. Perfect. So if you're not professional athlete level at this time, you can definitely do your cardio. You can definitely do your flat Rose Bowl walk.
Yeah, exactly.
Okay, perfect. Thank you so much for your time, Dr. Schroeder. This was super enlightening. It was a mini masterclass on lupus in the lungs. Thank you so much.
Okay, it was my pleasure. Thanks for having me.